Chapter 8, Professional Rescue, CPR. This chapter deals with all things with CPR, children, adult, and infant. Before we start our CPR, we obviously have to do our primary survey. Our primary survey is there to establish levels of consciousness, the ABCs, airway, breathing, circulation, identifying any life-threatening conditions, arterial bleeding, things like that, and assess for visual functions. And we need to begin interventions as soon as possible to preserve life. Primary survey only takes a few seconds to complete. Is he alive or is he dead? Anatomy and physiology is to use a simple knowledge of the anatomy and the function of the upper airway, heart, blood vessels, lungs, skin, mucus, and bones, and the foundations of emergency care. Pathology is a simple knowledge of shock and respiratory compromise to respond to life threats. Always remember CAB. When we're doing CPR, CAB, circulation, airway, breathing. Airway and breathing skills may be life-saving for a patient whose heart is still beating. To maintain and restore circulation manually, to perform cardiac compressions, to maintain both breathing and heartbeat, rescue breathing and chest compressions must be done together. Approximately 70% of patients in cardiac arrest are in a state of ventricular fibrillation. Okay, the other common one is ventricular tachycardia, exceptionally fast heart rate. The circulatory system consists of a heart, which is a pump, a network of pipes, the blood vessels, and fluid, which is the blood, which flows around the body. The heart is located in the chest between the lungs and consists of 4 chambers. 2 on the right, 2 on the left. Okay, each upper chamber is called atriums. Lower chambers are called ventricles. The chambers work in a well-ordered sequence to pump blood to the lungs and the rest of the body. One-way valves allow the blood to flow in one direction only. Take a look at the pictures over here. You can see on the picture number A, the deoxygenated blood, the blood coming back from the body comes in on the right-hand side, right receive. And you'll see on the B cut-off diagram, you'll see that the red arteries carry oxygenated blood from the body on the left-hand side, so it would be left leave. Easy way to remember, directional flow of the blood is right receive and left leave. Arteries carry the blood away from the heart under pressure. Smaller arteries branch off into capillaries, smallest pipes in the circulatory system. These things go through between the cells, and that's where gaseous exchange takes place, and nutrients and waste products are removed from the body at those points as well. Veins are thin-walled pipes which carry blood back to the heart. Okay, they don't have muscle layers in them. They have one-way valves, which prevents the blood from flowing backwards. When we're looking for a pulse to check if the patient is alive or dead, there are 4 major artery locations where we can find pulse points. Number 1, the neck, just underneath the angle of the jaw. 2 fingers down, you will find a carotid pulse or the carotid artery. The radial pulse or the radial wrist, if you run your fingers back from your thumb towards your wrists, just past the wrist bones, you will find a pulse point between the tendon of the thumb and the radial bone itself. Always finding arteries where the bone and the artery cross each other. Up in the upper arm, the brachial artery, so you'll find it just above the elbow joint. On the inside of the arm, between the bicep and the tricep. And in the groin, you'll find the femoral artery. It's not quite in the groin, it's more on top of the hip, in a straight line with the femur almost. You can try and look for it over there. If your patient is a little padded, you're not really going to have much luck in finding a femoral artery. Okay, these arteries are used to measure a pulse. How do we measure a pulse? Just a quick recap. We always count the number of pulse or beats in 15 seconds, and then we multiply these by 4. When we're talking about pulse, always remember to look for rate, rhythm, and quality. There's a good picture. Picture number A, carotid pulse. very easy to find because it's close to the surface of the skin and it is rather large. Radial pulse is the most common one where people look for a pulse to count. Always remember you can check either side of the body for these as well. Slide number C would be your brachial pulse. Okay, the only pulse point you're going to find on a baby or an infant is that one over there. Number D, as I said just now, is kind of difficult to find because most people look in the wrong place for it, number one. And number two, if you have a good layer of fat, that thing is going to be hidden quite deep underneath that fat layer. Okay, the anatomy and function of circulatory is the blood consists of several different components. Okay, obviously plasma making up the largest portion of this. The volume, the liquid that is used to carry the blood around, the red blood cells, the white blood cells, and the platelets. Red blood cells carry oxygen, they have hemoglobin, okay, and they also take the carbon dioxide back to the lungs. White blood cells are used to fight infections and things like that. And platelets are used in causing blood to clot. Okay, thrombocytes in the blood. These are what causes that blood clot for heart attacks, the thrombosis. All right, cardiac arrest occurs when the heart stops contracting and no blood is being pumped through the blood vessels. Without a blood supply, cells of the body will die. Brain cells between 4 to 6 minutes. Heart muscle damage occurs between 8 to 10 minutes, anything from there onwards. All right. Some of the reasons we could have a cardiac arrest, okay, obviously, heart and blood vessel disease, things like atherosclerosis, where there's a plaque buildup in the blood vessels in the coronary arteries. Respiratory arrest, if it's untreated, anything from choking to suffocation to laryngospasms, drowning, things like that. Medical emergencies such as epilepsy, diabetes, allergic reactions or severe anaphylactic shock, electrical shocks, and then sometimes poisoning as well, which cause that to happen. All right. Drug overdoses. In some cases, definitely your opiates would cause things like heart cardiac arrest, drowning, suffocation, and trauma and shock from massive loss of blood. We look at massive blood loss, we always talk about hypovolemic shock. Hypovolemic shock. A patient who's experienced cardiac arrest is unconscious and not breathing, you won't be able to feel a pulse. You're going to check in the carotid pulse, you're going to look in the neck, you're not going to find anything there. Okay, regardless of the cause, we need to start CPR straight away. A lot of people say sometimes they don't know what to do. Just do something. Anything is better than nothing. Remember, when we look at CPR, the components of CPR, we're always looking at CAB, circulation, airway, breathing. Okay. Circulation provides the forward movement of blood. Airway, if it's open, will allow air to move through into the lungs quite freely. And breathing, we may have to do rescue breathing or ventilations to assist getting some fresh oxygen into those lungs. Airway and breathing skills to determine we need to open an airway. The preferred way of opening an airway would always be the head tilt and lift maneuver. Okay, if you're suspecting that your patient may have a neck injury, a spinal injury, cervical spine injury, we're always going to use or try and use the jaw thrust maneuver. It is a little bit more involved and you need a few pairs of extra hands, but it's a safe way to make sure that the patient's neck or C-spine is not compromised. How do we determine breathing? Okay, we must always use the look, listen, and feel to determine if the patient is breathing or not. Look to see if the chest wall is rising. Feel to see if there's any movement of air on your cheek. And listen to see if there's any sounds of breathing or anything like that. Look, listen, and feel. In order to determine whether there's a pulse, I explained just now, we need to find where a pulse point would be. Palpate, in other words, use your fingers to feel if there's a pulse. If there's no pulse, we need to start performing chest compressions as soon as possible. Remember, with ventricular fibrillation and ventricular tachycardia, there could be, it would be pulseless, not could be, it would be pulseless, especially with tachycardia. The heart is beating so fast, there isn't enough time for the chambers of the heart to fill up with blood. Therefore, there would be no output or forward movement of blood at all. CPR by itself cannot sustain life indefinitely. It should be started as soon as possible to give the patient the best chance of survival. Many patients will need defibrillation and medication to be successfully resuscitated. One has to understand that a blue heart does not respond to defibrillation. So keeping the blood moving forward, keeping it oxygenated, the heart muscles, gives a better chance of the patient surviving and actually being resuscitated. We must always remember the links in the chain of survival. If we look at the picture on the screen right now, we'll notice that there are 5 links, although there's 6 in here, 5 links in the chain of survival. In order to survive a heart attack, your best chances is if you would have these 5 links in place. First of all, early recognition and activation of EMS. What are the type of things we're expecting to see if we're looking at early recognition? The patient will always be, obviously if there's not other complications, shortness of breath, pale, cold, clammy skin. They may feel nauseous and vomiting. They will also have a crushing chest pain, pain in the chest, okay, which radiates up into the jaw, the shoulder, down the left arm, sometimes into the back. Everybody is an individual, and all individuals will have these signs and symptoms in different or various forms. Okay, so once you've recognized the fact that the patient is in trouble, remember, heart attacks are not always just sudden and instant. Sometimes there's that pain in the chest, there's that impending feeling of doom, okay, that anxiety that nothing is going to happen, you're going to die, you need to make your business right with your family, and things like that. Okay, we need to start as soon as the patient becomes unconscious and there's no forward movement of blood. We need to be ready to start CPR. CPR is when we do cardiopulmonary resuscitation, and we keep the heart and the brain alive by getting the blood moving forward. Rapid defibrillation. Defibrillation occurs using an AED. It applies an electric shock, stops the fibrillation of the heart, and allows the normal pacemaker cells to kick in, hopefully, and continue the beating of the heart in a normal, regular pace. Basic or advanced EMS, we need an ambulance, we need people that are better qualified than we, and then we need ALS or post-arrest care. Good cardiac surgeon if there's a bypass needed, physicians, things like that. And obviously, adequate time for recovery after a heart attack is very important, and a healthy lifestyle after that. Let's have a look now, moving on. When should we start CPR? Okay, anytime your patient is not breathing. There's almost no chance of finding a patient that's not breathing that doesn't have a pulse, or that has a pulse that's not breathing. It's not going to happen a lot. It's a very small window, that type of thing. Unless there's obvious signs of death or do not resuscitate thing, then we are going to start doing CPR. Obvious signs of death, obviously we're not going to start if it's obvious signs of death. Decapitation, severe mutilation, bodily mutilation, cut in half a body, arms, legs missing, things like that, huge pools of blood and things, That's clearly signs of death. Rigor mortis is that point in time where that body stiffens up. The body must produces enzymes which keeps the muscles supple and soft, easy to move while we're alive. As soon as we die, it stops producing these enzymes and our body stiffens up for a while. Okay, other signs of death definitely is tissue decomposition. Okay, the patient starts to smell, the flesh starts to fall off, and there's definitely no chance of helping them. And then the last one would be lividity. Okay, as time after the body has been lying for a while, gravity comes into play, and the blood starts to pool on the lower surfaces of the bodies. If you have a patient, you roll them over, you will see almost purple or red colored parts of the body where the the blood is settled on the lower surfaces. All right. Only when do we stop? Before we talk about starting, when do we stop? We only stop once the patient starts to breathe again or is alive. He's got a pulse, he's breathing, and we can start slowing down on our interventions to help him. Hopefully by this time the ambulance has arrived on its way and they can take over. Resuscitation efforts are continuing until another trained person takes over from you, and then you can swap sides. It's important that if you've got somebody helping you doing CPR, that you alternate regularly. Okay. If you are now tired, you cannot continue anymore. Okay, you're finished. There's no ways you can go on. Then you obviously can stop. But we try and continue as long as possible. As I say, if you rotate regularly, then you can quite easily continue for a couple of minutes longer than normal. Obviously, if a physician or paramedic tells you to stop, we stop. Okay. Because they have the abilities and the knowledge and things like that to decide that that patient is no longer a viable option. Okay. External cardiac compressions, let's check. We check the carotid pulse to look for signs of life. Okay, coughing or movement. If there's no carotid pulse and the patient is unresponsive, we begin chest compressions. Okay. When we talk about chest compressions, we talk about two hands, center of the chest, fingers locked together. Okay, elbows locked, and we rock from our waist down. We do compressions at a rate of 100 to 120 compressions per minute. Our compression depth is always 5 to 6 centimeters, or 1/3 of the depth of the chest. We don't have time to measure 1/3 of the depth of the chest, though. Okay. Our compressions at a rate of 100 to 120, 30 compressions. After 30 compressions, we give 2 ventilations. Ventilations are only 1 second long, and we just want to see the chest wall move up and down. Remember, chest compressions for an infant, we're always using the middle 2 fingers, right? Make sure that if the baby's on a hard surface, you've got something under the shoulders, because a baby's head is a lot bigger than its body, so it tends to roll forward, closing off the airway. So if you're not holding the baby doing compressions and supporting the head and neck, make sure that there has a small towel or something folded up under the baby's back. To check for circulation in infant, we need to locate the brachial pulse on the inside of the upper arm. Okay, if there's no pulse, we begin chest compressions, the middle 2 fingers. Okay. How fast? 100 to 120 compressions per minute. 2 fingers, center of the chest. And we pressing at a rate of 100 to 120, 30 compressions, 2 ventilations. And we don't stop until the baby starts to show signs of recovery. Okay, compressions on a child is 1 hand. Okay, heel of the hand, center of the chest between the nipples. And we begin compressions at a rate of 100 to 120 compressions per minute, 3 to 4 centimeters deep, 30 compressions, and 2 ventilations. You must remember that with all of these CPR skills and things like that, if you can't get decent ventilations, don't wait. We can't stop. We need to continue doing compressions the whole time. 30 compressions, 2 ventilations. 30 compressions, 2 ventilations. All right. We need to keep the blood moving forward. The blood moving forward is what keeps these patients alive. We never want to interrupt for longer than 10 seconds to check for a pulse. After every 5 sets of or 5 cycles of CPR, we then start and we check for a pulse. If there's no pulse, we continue with CPR. We try and shock again if we have an AED. Otherwise, we just continue the whole time with the CPR, keeping the blood moving forward. All right, with the one rescuer for infants, ratio is 30:2. Okay. 2 breaths. Obviously, with an infant, we only use the air that we can fill in our cheeks. We just need the chest wall to move slightly. It doesn't have to overexpand. Because if you overexpand it, you're going to blow air into the stomach and the patient is going to vomit. Okay. 2 infant rescue is the only time that we will go from the 30 ventilations and compressions and ventilations, and we will do it at 15 and 2. But remember, we don't have time to stop in between. CPR on a child, we will just use this one hand, less force when we blow to ventilate the child. Okay. Exactly the same as adult CPR, except the depth of the chest varies and the force at which we're blowing. Okay. If you have an AED on your patient, it will time you for 2 minutes. Okay. Or allow you time to do 5 cycles of CPR. After 5 cycles, we either reassess the patient if we're alone. If we have a second rescuer helping us, we would then rotate and swap our jobs in this process. When we know that we have effective ventilation, okay, we can feel for a pulse in the neck on the carotid pulse. While one rescuer does compressions, the other rescuer will feel if they can find a pulse in the neck. Obviously, the patient's skin color will start to improve. Okay, the lips might be blue to start off with, but as time goes by, they will become pink. If you do capillary refill, there may be a white fingernail which turns pink in a couple of seconds. Okay, during ventilations, you will see the chest visibly rising. And make sure that these ventilations and compressions are delivered at the appropriate depth and rate. Okay, if you hear ribs breaking while delivering compressions, don't stop. Whatever you do, don't stop. Okay, make sure that your hands are in the proper positions. Don't let your fingers come into contact with the ribs. Okay, if you hear a cracking sound, check your hand position, but continue with CPR. Sometimes what you're hearing is actually the cartilage breaking and not actually bones breaking. All right, gastric distension. If you are going on for a long period of CPR, okay, you've been blowing, giving ventilations, blowing too hard, or the airway hasn't been opened properly, you will start to see that the stomach is blowing up like a bit of a balloon there. Okay. This is eventually going to cause regurgitation, okay? You need to ensure that the airway is open in order to avoid this. And don't blow too hard when you're blowing, okay? Regurgitation is common during CPR. To minimize this risk, okay, we then would turn the patient on his side if he starts to vomit or regurgitate. It's called the vomit drill. All right, turn the patient towards you. Make sure that you support the head and neck while turning them towards you. Once the patient is finished vomiting, you would then clear the remaining vomiters from the patient's mouth using a finger sweep. Okay, suction if there is suction available. We then return the patient onto his back, reassess the pulse, Okay, and then we would continue with CPR. It is important to make sure that everything is cleared out the mouth of the patient before we continue doing the rescue breaths. Otherwise, we stand the chance of forcing vomiters down into the lungs, and that would definitely not be a very good thing. Remember, space is required. Confined spaces are not always a good thing to have when doing CPR. We need to have a bit of space, at least 3 to 4 feet around us. 3 feet, so it's 1 meter to 1.5 meters space around your victim that you need, especially when doing things like defibrillation. You don't want to be close to the patient when shocking that patient. So remove them from the room, take them off the bed if they're on a bed, and things like that. All right, more than 70% of all out-of-hospital cardiac arrest patients have an irregular or a heart rhythm called ventricular fibrillation. With VFib, it is recognized by a rapid, disorganized, ineffective vibration of the heart. Okay, an electric shock is applied to the heart and will reorganize or allow the normal pacemaker cells to pick up a regular heartbeat. The greatest chance of survival for a VFib patient is the prompt use of an AED. That is why if you have 2 people doing CPR on a patient, while the first person is doing compression, the second person would be already setting up the AED on the patient in order to shock as soon as possible. For every 1 minute that goes by, we have about a 10% less chance of surviving without shocking. Most AEDs come with either visual or both visual and voice prompts. Okay, they've been programmed to identify ventricular fibrillation or ventricular tachycardia and advise the rescuer when a shock is needed. Okay, you will get a chance to use a training AED and follow the sequence and see how it works. Okay. All right. Legal implications of these things. Advice directives and living wills are legal documents that specify a patient's wishes regarding specified medical procedures. CPR should be started on all patients unless there's signs of obvious death. Okay, decapitation, lividity, tissue decomposition, and rigor mortis. If a patient is an advance directive, in other words, a physician at hospital will determine whether you should stop CPR. It's not up to you to stop. You will do CPR. Okay. Do not hesitate to start his CPR on a pulseless, non-breathing patient. The patient will die without you. He is already dead. If you do not start it, he's got no chance of surviving. Abandonment, in other words, once we have started treating our patient, we can't decide that we've had enough and it's time to go home. We need to continue helping the patient until at least somebody that's equally trained as what you are or higher trained than you to come and take over your treatments. Thank you.